Can you hear? Because if not, Jared threatened to heckle me about my own deafness. Well, I've decided to speak today in a new role. It's a role you've probably never heard of. It's not an official role. It's not approved by Dr. Golly or Dr. Mills or pretty much anybody. I have self-appointed to be the educational Lorax of our department. Don't I look? I hope to be something like the Lorax, who I hope you remember was a children's book character, who spoke for the trees because they didn't have a voice of their own. So today I hope I can speak somewhat for you as well as to you about some important matters, some of which will make us uncomfortable, and that's okay. I think we need to be uncomfortable about these things. There's a problem that I perceive. You may or may not perceive it. Either way, it's okay. And the problem is that I think all of us, have lost sight and are losing sight of many of our educational goals. We came here for a reason. Right now, we are in the throes of a cultural shift that I and maybe some of you find frightening. We're being thrown into a world of cash. We're in a world of cash, a world of RVUs, a world of private practice values and venues, assignments that many of us didn't know we were going to be up against or playing with, or however you want to put it. These new paradigms are scary to me, and maybe they're scary to you, because I came here for another reason. What I've been hearing very little about, a lot about RVUs and cash, private practice, very little about education lately. Maybe it's because we're so preoccupied with cash and whether we're going to survive individually or as an institution.
On?
It was when I looked.
And the batteries are in?
Now it's on.
Say something.
Must I? Okay. You weren't missing much. Don't worry. So, I've heard remarkably little about education. I understand why, but that's not tolerable to me. So what I'd like to do is to help focus us on some educational issues, some ways that we can teach more efficiently, teach better, use other tools that don't cost a lot of money, ways that we can make things happen, even in our present milieu, as troubled as it may or may not be for each of us. I'd like to, in light of the Latin of my title, I'd like to encourage you to allow this to be a forum and to speak up. You, any of you, all of you, may have an opinion on this, and I'd like you to say it out loud. Interrupt me. Don't wait for the end. So don't be shy. I have no disclosures. I have only one job. I don't moonlight at Willis Knighton. I don't do anything but work here. So, our agenda. I've already told you what I think the problem is, and that's loss of focus on our education. I want to talk to you about some solutions. I'm going to talk about teaching, my 40 years on the front line, and just a lot of semi-random thoughts about how to teach better. Then I want to talk about an opportunity that has been lost that I hope we can regain, and an opportunity that is there, just not being taken care of. And so let's talk about developing the right philosophy to teach well. You have to decide what you want to teach. And given that there are limited opportunities and becoming more limited possibly, you want to do the most and the best in the least amount of time. So you have to decide what you're going to teach. And you have to have the right philosophical approach. And the way I think it works best is to ask what is so important that you would like your learner, and I'll use student as a generic learner, whether it's intern, resident, student, or me when I'm sitting in the room. But what do you want us to remember 5 years from now? And concentrate on that. Aim towards it. Even if you have to do it a little bit at a time, one tiny piece. But if it's not something important, it's not going to be remembered. It won't get the value it needs. Whether you're teaching in the classroom, in the lecture hall, on rounds, one-on-one in your office, the principles that you use to teach are always the same. There's no difference. The idea of keeping people interested, telling them what they need to know, helping them understand why they need to know it, is always going to be there, whatever the setting, whatever the venue. All learning is contextual. No matter how random you think the thoughts are, if you give them on a framework, if the framework is there, and I always thought of it as a Christmas tree. If you have a Christmas tree, you have a place to put the ornaments. The Christmas tree is the framework, the ornaments are the facts. The tools of learning is what you're using. So you have to present it, make sure the framework is there, and if the framework isn't there, your job is to first install the framework. Basic principle of adult education. And I don't know if it's like this in elementary school. I've never taught elementary school. But the basic principle of adult education is that the students educate themselves. And we're involved in strictly adult education, although for many of us it doesn't seem that way. We can inspire you. We can help you learn how to do it. We can role model education for you. But you have to do the learning. The student has to do the reading. The student has to attach the ornament to the tree. We can give you the ornament. We're often called upon, for instance, how about this room as an example, to engage learners who have many different styles of learning, who have many different abilities to learn, who have many different abilities, period. On rounds, we have the same thing. We have everything. We have junior medical students. We have senior medical students. We have interns. We have senior residents. We may have pharmacy students. We may have PA students. Everyone learns at a different level. Everyone has to still be taught at the same time. Have you thought about how to do that? Chess is an interesting game, and I wish I played better. But I'm interested in chess, and I'm interested in teaching of chess. And chess has a lot of similarities to medicine, especially internal medicine, because it's where we solve problems. We anticipate things. We try to cut things off at the pass to prevent things. And teaching chess seems to be a lot like teaching medicine. And a fairly well-known grandmaster, Roman Peltz, is a very well-known teacher in Russia. And he has said he likes to teach in classes of about 10. And in a class of 10, he says to teach to the third from the top. And that way, the lower end has to learn up, but the people at the top will learn by teaching. They may know some of what you're teaching, but they'll help you by teaching down to the students who are at the bottom. And that's how we have to do it when we teach groups of varied styles, varied sizes, varied abilities, and varied development already. So keep that in mind, because on rounds we're asked to do that every day. Rounds. Another word for rounds, another phrase for rounds in education speak is collaborative small group learning. You didn't know we were doing that when we go out there every day. It is the venue that I feel most comfortable in. I hope you feel the same angst as I do when I speak to a group like this. This is not my venue. My venue is going on rounds with a handful of people. But I'm happy to say that actual studies have shown that learning occurs better in that group. It's more personal. It's more one-on-one. You're more involved with what's happening than here sitting in this group. In addition, on rounds, in small collaborative group learning sessions, you learn how to teach and you learn how to learn later in your life. It's more applicable to what you do. So I am a great proponent of the small group learning style. One thing we can teach, we can role model, and we have to, and we don't do it well enough or often enough, is teaching how to admit that you don't know. Because once the supervisor, once the leader can admit that he or she doesn't know, the whole group can go out and learn, and we can all learn how to find out together. And that's what our great organizations, our educational organizations, like to call lifelong learning. And we need to take it seriously. That's hopefully why everyone's here today. When we do lifelong learning in groups, we all learn together, and we learn how to teach together. Move beyond anecdote to evidence. One of my students in South Carolina, who actually eventually became quite a successful intensivist, used to always taunt me by telling me that the plural of anecdote is not evidence. Now you can say, well, if you get enough anecdotes together and you apply a t-test to it, and well, it can become evidence. But just anecdotes are not evidence. I've seen this happen is not evidence. It's better than I've never seen it happen, but it's just not evidence. So if you can go on and teach from evidence, people will remember it. People are impressed that there is a reason that you're saying it. It's not just that you're saying it because you can. On the other hand, some of us have a big weakness in that we use a lot of anecdote. Maybe it's okay, because an anecdote can make it more personal, more memorable. If it's based on evidence, if you use it to illustrate evidence, to make the evidence more relevant to you. Remember when your parents told you that first impressions matter. Once again, your parents were right. When you start a session, a day of rounds, a class, a lecture, a course year, you have to get their attention. Make sure people know where it's happening, and it's got to happen with you. You've got to be animated. Show them you're awake. Show them you care, because if you don't care, nobody's going to care. You're the teacher. You've got to hook them in the first few minutes. If 10 minutes go by and people are daydreaming, they don't know what you're talking about, they don't care what you're talking about, you've lost at the minimum that day. And you may have lost the whole series of the course. You've got to show everyone why the subject matters. Show them why it's important to you, why it's going to be relevant to them. It can be that, you know, this is going to be on your boards, Ty. You better listen. Or there's going to be a patient come in the middle of the night with heart failure, and you're not going to know how to fix that patient, how to get them breathing again. You're not going to know what that arrhythmia is unless you pay attention to this. You've got to challenge. Challenging can be difficult because it makes people uncomfortable. Everyone likes to sit there and feel they're not going to be called on. Maybe that's why I like small groups, because I can do what I like to call, and you probably don't like when I call, give you the finger. Right, Zid? Okay? You've got to make people know that they're awake. We always talked about setting the goals and objectives at the beginning of a session, whether it's the beginning of a couple of weeks or a month of rounds, or whether it's the beginning of a course or the beginning of your whatever the lecture is. And the very phrase, "you will be required to," is enough to get people's attention. It's enough to set a standard that people know they have to follow, that will not be deviated from. It's a very formal phrase. Don't be afraid to use it. I like turf. Not surf and turf, that's good. But turf in that it's your area. When you're teaching, you have to own the room. You have to own the platform. You have to own the projector. It's your turf. You have to own the little circle that your group is standing in when you're making rounds. When we work with each other, we have to be respectful. There is a lot written on the negatives of teaching by terror. Now, when I was in school, there was an old New England ID doctor. I don't know, did you ever hear of Richard Hardy Mead? He was a pediatric ID guy, worked with Louis Weinstein. He was Louis Weinstein's torpedo, basically. And every day on rounds were not complete until Hardy Mead made someone cry. Truly, it was unbelievable. Residents, some days residents cried, some days students cried. Every day, we had to humiliate someone into crying. Well, it gives you a reputation, but I'm not sure it's the reputation you want as a teacher or as an institution. If you treat people with respect and help them understand what they know and what they don't know and how to learn what they don't know, that won't happen. And it's not respectful to beat on people. What can you use to keep discipline, to keep the attention where you want it to be? Well, you use yourself. You use your personality, your persona, who you've become, what you represent to your group. You can use your age. When I was young, I couldn't use my age. Now I can use my age. Now I'm an old Jewish guy, and I can use that. I didn't used to be able to. Use your cultural differences and similarities to make points. People remember it. Dress the part. Spring for a bow tie. Won't kill you. What's that? What's that, smart Alec? Yeah. Yes, you do. Do you have something else besides bow ties? A few. I have none. Anyway, so you can dress the part. It puts you where you have to be. These sound like trivial things, but if you add them all together, they're not trivial. Put them all together, they do spell mother. I didn't agree with much that Seth Burney had to say. Whatever. I did agree with one thing. He made residents and students wear a dress shirt and tie when they came to his clinic to see patients. I don't do that, but I agree with doing it. It's okay. We have to play our role, and people understand your role both from what you do and what you say and how you look. And how you look isn't everything, but it's a piece. You have to understand it that way. Believe it or not, there is actually a very large literature about dress code and house staff. It's amazing that we would devote literature to this over the years. It counts. Act with benign equality, but there are boundaries. So again, when you're teaching, you have to be everyone's friend. And by the way, this stuff may sound sort of addressed to different people than the house staff, but it's not. This is addressed to house staff. It's addressed to Dr. Mills. If Dr. Ghali was here, I'd address it to him. And it's addressed to any student here because we're all teachers, and this is pertinent to all of us. And if it's not this year, it will be next year. Okay? You can poke fun at someone, but you can't poke fun till they cry. You have to know what the boundary is. You have to feel it out and know. You have to avoid the perception of favoritism. Okay, we've got a lot of smart people here, so I'll bet half the people here at one time in their life were the teacher's pet. Okay? I was never the teacher's pet. I was always the teacher's pain in the neck. Okay? But I was always resentful of the teacher's pet, and I don't want half your teams to be resentful. So everyone has to be treated equally. This is important now. Be consistent and true to your persona. Do not run hot and cold. When I come in the morning, some days I feel great and energetic, and I want to teach, and I know what I want to teach, and I know what I want everyone to learn that day. And some days, I get in the car after the dog peed on the carpet, I had a fight with my wife, and I forgot to take my lunch with me. And I come in, and I don't want to see people. I don't want to do anything. I don't know what I want, but I don't want to go and teach and be the life of the party. And then I get in the room, and all of that garbage drops off of me. And I'm back where I belong. I'm back teaching like I want to teach. The same thing happens to you, but you have to let it happen. You have to be aware and not carry your baggage in with you. You have to let it drop off. If you're not conscious about it, it won't happen. You have to be friendly yet aggressive. If you let people sit there, not think that they're going to be addressed, not think they're going to be called on, let them think that someone else is going to answer the question, someone else is going to care for the patient, you will get nowhere. You have to keep challenging, and you have to keep the mood taut but friendly. If it's not edgy, it won't work. Otherwise, people won't be able to answer because they don't have to. They don't think they have to. If they think one person's doing it, that's not enough. Everyone's mind has to be kept working. Team spirit. A couple of days ago, I was talking to the dean at another medical school, and he was telling me how they send their students out to these rural hospitals where there are no residents, and they I forget, it's not shadow, but they go around with attendings, and they learn from individual attendings one-on-one, and that's great. And so I said, so how do they go and become interns and residents? What happens when they go on and they have to continue their training out of medical school, out of this shadowing relationship? How do they learn how teams function? And he lowered his voice. He said, well, you know, they do just as well as everyone else, just as well as team-trained students on USMLE and on shelf exams. I said, but how do they function when they get put on with teams? He said, well, it takes them a while to get up to speed. They have to learn that. So teaching about team function is very important. We function as teams. Certainly in academic medicine, we hardly ever function not as a team. We need to emphasize that. Balancing seriousness with humor. I think everyone's got a sense of humor. When things get too taut, putting some humor in is the reset button. It gets you back. It breaks that sweat. It lets you relax and start fresh again. It works. Use cultural references to teach and to identify with your learners. We have a lot of people who are from different places, a lot of people who are from very different places. I'm from the Northeast. Okay? We have places, people who are from even stranger places than that, Florida. Explain what your references are. I've got a terrible problem. I have a generation gap. Okay? I'm old enough to be your grandfather. Hey, that's a generation gap. I have to explain. I had to explain to someone who's Jerry Lee Lewis and what are Great Balls of Fire this week on rounds. Okay? So use cultural references, but make them useful to everyone. Okay? Plan your teaching. Teaching just doesn't happen. It's spontaneous, but not. Okay? If you plan it, you can teach less, but teach better. Therefore, teach more. If you teach, and we spoke about this, foundational materials, teach how to reason, teach what the foundation is, and then teach them how to find the facts. Reasoning is the most important thing that we can teach in internal medicine. I don't know about the other specialties. I don't know what they teach, what they do, but we need to learn reasoning. Don't bite off more than you can chew. You cannot teach all about cardiology in a week, or a year, or a fellowship. Bite off a teachable amount that you can get people to learn and work it. You can't teach about everything, so choose what you're going to teach. Use repetition. Summarize at the end of each session. My wife detests speaking in front of large groups even more than I do. She gets even more nervous than I do. And when I first started doing this a long time ago, somehow she knew what to tell me. And everyone's heard this before, but you'll hear it one more time. Tell them what you're going to tell them. Then tell them what you told them. That's how you teach. It's so simple. Be flexible. Go with the flow. So, in another 5 minutes, when I see everyone trying to get up and leave and sneak out, I got to change the subject fast. I got to get your interest back. Lectures. So, a lecture is this. A lecture is what I'll do next year in front of the Nobel Prize Committee. Oh, no, I'm not doing that. A lecture is what we do for 5 minutes at a patient's bedside when making rounds and we break to talk about something and explain something. So there are mini lectures, maxi lectures, and everywhere in between. But a lecture should be conversational. It shouldn't be read. There should be eye contact. It should be enthusiastic. Try to vary your voice. If you present in a monotone, all is lost. It won't work. No one will sit through it awake. They may sit through it, but not awake. You can ask and answer your own questions. Use whatever technique you have to vary the presentation. Avoid verbal tics. You know, like, sort of, and what. I have a whatnot story. There was an oncologist, a hematologist actually, in Columbia, South Carolina, who used to give lectures for our residency. And he was a and whatnot man. He used that so much that I and some of my snottier colleagues sat in the back of the room one day for a 1-hour lecture and counted 50 and whatnots in 1 hour. He obviously became known as Whatnot Man. Don't do that. It is distracting. Allow questions. I haven't heard any questions. I'm sad. This must be so outre that no one wants to engage me here. But don't interrupt yourself with any questions. Just let people know that they should ask questions when they have them. Once again, use analogies. My wife tells me I live for analogy. Perhaps I am an analogy. Explain your analogies, as I said before, and remember that these cultural and generational gaps exist, and it's your job to get over them, to tell people what you're talking about and why you said it. Use gestures, but watch out. A single repetitive tick gesture will be annoying and distracting, and swaying can be annoying. Yes, dramatic silences are okay. It's not just psychiatrists who make use of silences. Always watch the clock, not from the audience, from the speaker's platform. Always watch the clock. I remember a physics teacher when I was in college who got very upset with us one day while giving a lecture, and he said, "I don't mind if you look at your watch, but I don't want if you're constantly doing like that to make sure it's still working during my lecture." Pace your lecture. Don't spend the first 10 minutes over 40 minutes and then fit 40 minutes in the last 10 minutes. It doesn't work well. People don't learn that way. One-on-one teaching. We're talking about trying to be economical and getting more teaching in less time, more teaching in period. But one-on-one teaching, while not maybe cost-effective, is effective. It works well. It gets people working with you. It builds loyalty. So make the opportunity to do it. Interestingly, it's been theorized that students may feel less uncomfortable about being wrong, about giving wrong answers and making mistakes in front of just the teacher than in front of the teacher plus an audience of their peers. It's less humiliating, perhaps. What it clearly is very useful for, though, is for giving feedback, which frequently needs to be given, almost always needs to be given in private, whether it's formative or summative feedback, to clarify ideas that an individual doesn't understand but the rest of the group is okay with, for being empathetic, and for just listening to what your student has to say. A good lead-in for seeing things from the learner's point of view. Learners can be inexperienced. They can have the life issues of youth. Things that bother people who are young just kind of flow over old people like I am. How do you learn best? Dealing with different learning styles, and we'll talk a little bit about that later. What do the learners like? And you have to remember that if you can't remember what it's like to be a student, you'll never be an effective teacher. You have to remember what turned you on in a subject in order to get other people turned on. We're all similar that way. Different learning styles. This is a hot topic. It cycles up and back, but currently it's fairly hot in educational circles. We have to teach people of many different learning styles. And so, over time, everyone will get something. Everyone will get some visual, everyone will get some auditory, everyone will get some written. Everyone can go home and study in peace and quiet. But it turns out that there are actually that the learning style issue may be a little overblown because there are more similarities between people's learning styles than differences. So you may learn best visually. It doesn't mean that you're deaf to auditory learning. It just means you do a little better visually. And so if we can teach a little bit of each style over time, will likely hit enough points so that everyone can learn. On the other hand, if you're really not getting the point across to some people, you may have to teach the same point in several different ways. Explain it orally, draw a picture, make a graph, go over it again, make sure they understand that they've gotten it in enough ways. I'm a big fan, for better or worse, of liberal arts and liberal arts teaching in medicine. And that is, we need to learn about other specialties, what makes them tick, how do they think, so that we can work better with them and achieve things for our learners and our patients. We also need to be teaching cultural literacy so we can identify with other people, our patients, our nurses, everyone. You need to be able to make a conversation, even if you're a doctor in the hospital. Maintaining your enthusiasm. Obviously, this is crucial if you want to have a long career in medicine or in academics. First thing is keep learning. If you're not learning, you won't be able to teach. Go to scholarly meetings. This seems all very simplistic. It's amazing that people need to be reminded. Attend faculty development. That's where you learn how to teach. I like to go to the ACP national meeting every year. About 30% because I learn a lot of new things in medicine. About 70% because it's the best medicine teachers in America who strut their best teaching out. It's where I learn how to teach by going to those meetings every single year. It's not just the facts, it's how to present the facts. Make education one of your scholarly interests. Oh, this is the third time I've said it. Use humor. Make it personal. Tell us how what you're teaching relates to your research, to your life, to your work. Interact with your learners as personalities. They're all individuals. They're not just sponges sitting there. They have lives and they interact with yours. Ask other teachers. Go attend other teachers' rounds. See how they teach. See how you could do it better. And ask other people to attend your teaching and critique you, help you to do it better. I hope that was random enough. But as Ron Popeil said, but wait, there's more. A lost opportunity. I hope this makes us uncomfortable what comes next. It's what I call the variance dilemma. Okay? We have a system of reporting things that we don't like in our institution called the variance. The variance should and could be a very powerful learning and teaching tool for individuals and for the institutions that we exist in. Here instead, and some of you may agree, some of you may disagree, but I'll bet I get more agreement than disagreement. It's used as a weapon, as an open-handed slap, an insult, an embarrassment at someone who's irritated you. The variance should ask, how did the system fail us? Where did the safeguards not fall in and stop something bad from happening or force something important to happen? Why did the system not allow it to work right? Not, who shall we crucify today? Variances need to be investigated in a non-accusatory way, even if the email at the end says this is not accusatory. That's not what it feels like. I don't know if you felt it. Preferably consulting the peers of the people who are involved so that we know what's involved on the front line. Not just some supervisor saying this should never happen. There's a reason things happen. So it needs to be involved by people at all levels. To be effective, the variance process has to achieve closure by giving effective teaching feedback on whatever happened, not just saying, give me your excuse and I'll close the variance. That's ridiculous. There's no learning for anything there. It can't be effective until the phrase, I am going to file a variance against you, is extirpated from the lexicon. Okay? This means we're not doing it right. There has to be a shift away from blame and towards change and improvement. Can it be done? Absolutely. It has to be done. And still more. Another opportunity to teach and to learn, and it's called consultation. And consultation has been around, obviously, since the time of Hippocrates, who wrote, physicians who meet in consultation must never quarrel or jeer at one another. Does this sound like some of our consultations? Dr. Everett, the private secretary to Monroe, said whenever Thomas Jefferson saw three physicians together, that's a consultation, he looked up to discover whether there was not a turkey buzzard in the neighborhood. Bad sign. So what is a consultation in an academic teaching center? Tool for communication between services, a request for knowledge, request for assistance, a request for a procedure, a means of documenting that those other things already occurred. What has not been mentioned? Isn't it a teaching tool? Shouldn't it be a teaching tool? Why isn't it a teaching tool? Okay? So what can we learn from consultation? Why do I think it should be a teaching tool? It teaches real-world interprofessional behavior. When people go out into practice, many of us have lived off of consultation fees. We're consultants, internists in many specialties. It teaches collegiality in time of stress. Things are going bad for my patient, therefore for me. Help me. Sure, I'll be happy to. Not, why are you so stupid you can't take care of this yourself, as I was asked this week by someone. It teaches us how other services work and think so we can deal better with them. How to improve patient care, communication, and patient satisfaction. To learn about issues in our own specialty that cross over, that involve other specialties. To learn to be civil and collegial and co-manage when necessary. And to become familiar with the evidence-based literature that involves more than one specialty. Okay? So, how long do we anticoagulate a knee replacement, a hip replacement? Do you stop Coumadin when you send someone for cataract surgery? Okay? There's a big literature on this. 1983, the good old days, right? Were you born? Lee Goldman, of the Goldman criteria for pre-op consultation. Thomas Lee, who was one of those who helped develop the accursed RVU system. And Rudd published in the Archives of Internal Medicine a short two-page article called 10 Commandments of Effective Consultations. This article has been spoken about since then. This article has been revised by team after team after team and published again and again. But as in Mount Sinai, there's nothing like the real thing. So I'm going to talk about their article. And they said, first, determine the question. I say it as all consultations must be asked in the form of a question. Maybe you've heard me say that. They looked at consultations in their institutions, and they determined that among the requester and the deliverer, 15% of the time, when there was a question, 15% of the time, the two sides interpreted the question differently. In 24% of the consults, no question was asked, and in 12%, a question was asked and was ignored by the person who performed the consultation. What kind of way to run an airline is that? So find out the question, call, ask if necessary. Okay? You can do a good job on a consultation if you know what you're supposed to do. So you could think of it as beginning your first line as, I was called to see this 56-year-old woman with breast cancer to determine the reason for leg weakness. Tell them why you're doing the consultation. Show them that you're answering the question. Then, establish the urgency. Stat consults need to be done stat. If you're not going to, you need the requester needs to know why. So the requester may need to call you to tell you how urgent this consultation is when it's urgent. If it can be done any old time, it's a 10-year-old problem that they want some feedback on, it can wait. But if it's urgent, let them know. And if you can't deliver, let the requester know. Let them know why. Let them know what to do meanwhile, whether it's who to call other than you or what to do until you get there. Look for yourself. Look at the evidence. Review the record. Review the record. Review the lab. Review the imaging. Take the history. Don't believe what other people have told you. That's what we do in internal medicine. We find out for ourselves. Be as brief as appropriate. This is a good setting to summarize things. You can write down an extensive level 5 H&P for billing. It ain't going to get read by no one. Okay? If you summarize in 2 sentences what your findings are, what the difference is between what you found and what other people found, it will be noted. You can write that long thing, just know that no one's going to pay attention to it. So tell people where your findings differ. Be specific. This is the most important thing. Detailed discussions and references are important in an academic consultation. This is how we learn. If I wanted a recipe list, I'd call Julia Child. I wouldn't call a doctor. Okay? Giving me references is teaching me how to fish, so I can fish for the next patient. Don't just hand me a recipe. However, there's always a however, isn't there? However, when the surgeon just wants you to take care of the patient, take care of the patient. You can still give a reference. It won't harm them. Knowledge won't destroy their surgical technique, but they still want you to help take care of the patient. Make explicit suggestions. Make your suggestions important ones, the pertinent ones. The longer the list, the less likely everything is to be done. And the really crucial suggestions may be the ones that don't get done because people don't know your priority unless you tell them. You don't need to leave a long list of expensive things to do just to show you're the expert. I've been told that, but I've asked people, why are you giving us this big list of things? Well, we're specialists. People expect us to do that. No. People expect you to be smart, not wasteful. So you don't leave a long list just to prove you're an expert. The number and cost of the recommendations in the study done by Goldman did not correlate with the impact of the consultation. Okay? Provide contingency plans. If this doesn't work, do that. If that doesn't work, call me. Call me if you've done this, next step is to add this, increase that, take that away, test for this. Make it 2-step and 3-step. Honor thy turf. Okay? So, if you're out in private world and you see a patient, your job is not to steal that patient for your practice. Your job is to take care of the patient and help the person who called you to see the consultation. That's not a problem we have here, but you won't all be here forever. So work out the details of co-management. Find out what the other service is requesting of you. Find out if they're asking you to write orders or just make suggestions. What if the patient says, so doc, what do you think? Should I have this surgery? Do I really need that test? Well, you have a dual duty here. You have a duty to the patient and a duty to the person who has asked you to do the consultation. And probably, most of the time, the best way to handle things like that are to speak with the person, the physician who asked for the consultation. Work it out through them. Negotiate it through them. You really don't want to embarrass them and put them in a bad situation. Also, if you speak with the person who asked you to do the consultation, they may know things that you don't know. They may tell you why they're doing a certain thing that was not in the record, that you didn't understand. So teach, and then teach some more and some more again, but do it tactfully. Make your references pertinent, on point, discuss them, teach them. But don't question the competence. Don't internists know how to take care of hypertension? Yes, we do, but sometimes we need advice and help from someone who knows more. That was last week's special. Always be generous and polite. Do not demean each other, like Hippocrates said. And talk is cheap and effective. Communicate with the patient, with the team who asked you to see the patient. We can work better as a team. Follow up. See the patient and follow up. Even after you've signed off, check in now and then. Find out, are things going all right? It also helps you assess whether your consultation was successful and effective. If they followed or if they didn't follow, you'll find out if it worked. Which famous doctor wrote this? Okay? Unless someone like you cares a whole awful lot, nothing is going to get better. It's not. I think I hear it. Dr. Seuss, the Lorax. Okay? To do what I told you I would do and review. We've identified a perceived problem, loss of educational objectives in our sea of financial turmoil. We've discussed 3 patches that we can use to try to improve the situation. Better teaching techniques, transforming the variance, a basic pain in the behind, into a teaching tool, and expanding the consultation into a teaching tool, a teaching and learning tool. And we've considered quotations from both Catullus and Dr. Seuss, all in the same hour. This is a quotation from the Roman poet Catullus. It says, "Hail and farewell," and it's come to signify a military transfer when an existing soldier or commander is being relieved and a new commander, team, soldier is taking over. It is of moderate to great likelihood that this will be my last opportunity to address this group in this sort of a forum. And I want to wish you all the best. As Porky Pig said, that's all, folks.